we're going to go through cases that I have seen in the past. One case is I did not see. However, it's from one of my ex-mentors, and thus, and it's an excellent case. So I deemed it necessary to kind of add that in here. So, what I want the fellows to do is to gain a perspective of ID from what, I saw both in either training or as a junior faculty member in different places. So I want this to be interactive. I want, fellows and if faculty like to chime in to basically, contribute to what we're discussing, whether that be a differential diagnosis, a syndromic diagnosis, other ideas they had about the case. I kind of want that to play into this. Also, everything you read in textbooks, once in a while does occur, and it is illustrated in some of these cases. So, and I guess Occam's razor. Everybody talks about this, that if it's you hear hoofbeats, it's probably not zebras. It's probably just a regular old horse. Sometimes it is a zebra though, so you got to be prepared for that. You have to know the anatomy as well as surgeons do. I know that's probably unpopular thought amongst ID people, but you've got to know the anatomy. You have to be able to describe it appropriately in your notes, and always go back to the history. You will see that I identified things that in the history of some of these patients that kind of contributed to their diagnoses and really helped out the case. So let's begin. So this is case number one. This is a 34-year-old construction foreman presented to an outside hospital in Florida with fevers, night sweats, and a 15-kilogram weight loss. He told me he was changing his shirts about twice a night because of the amount of night sweats he was having. Said it was been happening for about 6 to 8 weeks. On review of systems, the only thing else that was positive was a non-productive cough. The rest of his review of systems was negative. So he had a neonatal diagnosis of a VSD and a coarctation of the aorta. He was repaired at UF Shands at age 1 month and had a revision when he was about almost a little bit over 10 years old. And he has a HemoShield graft. In addition, he also has a pacemaker. So just to kind of remind everybody what a coarctation of the aorta is, you probably remember, but still, the defect can occur anywhere in the arch, but usually it's, after the left, brachiocephalic artery there, or the innominate artery, as they call it. So just to kind of understand this, also, again, VSD also occurs in some of these patients as well. So the rest of his past medical history is what I've already described. The only thing he does is he does have bruxism and from time to time chews on the inside of his buccal mucosa. So he has no drug allergies. He doesn't have to take any medicines right now. And his family medical history is negative for cardiovascular disease. So he lives in northern Orlando. He is married, doesn't have any other sexual encounters that he reported. No habits, no pets. And the only travel is once in a while to the Tampa Bay area and also to the Space Coast, which is not uncommon for residents of Orlando. So he's a foreman of a construction crew. He really doesn't do any of the construction per se, but he does oversee it, and he is on the job sites. So his hobbies are freshwater and saltwater fishing and also golf. So physical exam, he was, I guess you could say, had an elevated temperature at 37.8. He was paced at 75, and blood pressure was stable. So, he didn't have any stigmata of infective endocarditis. The only thing that was positive on his exam were the following. He did have these lacerations on the buccal mucosa bilaterally, so you could tell that he was biting his cheeks. He did have carotid bruits and that loud systolic ejection murmur that was radiated to the carotids that is significant for repair of both VSD and also coarctation. So the rest of his data, his white blood cell count was 10,200. Slightly anemic for being a man at 39 for his hematocrit. Platelets were 467, and his GFR was stable. So his chest X-ray really didn't show anything except for old surgical relics from the coarctation repair. So can somebody, one of the fellows, give me a syndromic diagnosis? Anyone? Whoever it is, I can barely hear you. Put up your volume, please.
Possibly an endocarditis from
Okay.
his oropharyngeal mucosa landing on his grafts.
Okay. Good job, Drez. So, 36-year-old guy with history of coarctation and VSD repair when he was younger, and a renewed surgery when he was 10. In addition, also has cardiac hardware in addition to the graft. So, his differential diagnosis is endocarditis or an endovascular infection per se. But what organisms are we talking about here? Anyone?
You could have strep species.
Okay, so streptococcal species. What else?
You could have culture negative endocarditis. So I came in the middle of the presentation, but culture negative endocarditis. So
Okay.
thinking about like HASEC group.
Okay. Who's pretty good. Somebody else, I think that's probably John Tony with in his house.
Yeah, and I don't know if he's been to like out in the country or anything, and kind of missed that part, but Coxiella would be another one.
Okay. I could see that if he doesn't really frequent any areas where there would be any ranched animals,
Yeah.
but he does go freshwater fishing, and in Florida those two environments can be mixed. Any other thoughts before we move on? Okay. So
could be staph infection.
I'm sorry?
He has a hardware, so could be a Staph aureus. So
indeed. So any kind of staphylococcal infective endocarditis is in play here. I concur with that. So let's move on. So his echocardiogram was positive for a small vegetation on the aortic leaflet. Otherwise, there was nothing else wrong with it. So this is his microbiology. So Harish was on the money here. So on both October 20th of that year, he had 2 out of 2 bottles positive for Cardiobacterium hominis. On the 23rd, he had 2 out of 4 bottles positive for same organism. 25th, it went down again. And again, by the 29th, his blood cultures were negative. So the sensitivities for the Cardiobacterium hominis were penicillin, ampicillin, ceftriaxone, cefpine, meropenem. So it's a pretty sensitive bug. So let's talk about this bug briefly. So it's a small gram variable bacillus, but it's really gram negative in composition. It is oxidase positive. It is catalase negative, nitrate negative. It does make biofilms. Can usually grows between 3 to 5 days, but also can grow up to 3 weeks. And this pictograph here from the Journal of Clinical Microbiology shows eloquently what the gross microplate looks like, and then going all the way up to 1000x, where you can see that they're these gram variable bacillus, but there are gram negative in origin, so they have more. They retain more of that saffron red. So HASEC organisms causing infective endocarditis. So again, cardiac implantable devices, pacemakers, these shield grafts are classic for this. A lot of them have congenital heart disease. And again, 2 to 3% of all infective endocarditis. And so what does HASEC stand for? So it's Haemophilus agricobacter, which used to have another genus name, Cardiobacterium, which is the one that this patient had, Cannella, and Kingella. So again, they're all gram-negative fastidious bacteria. So the treatment guidelines, this is what's interesting. So, the American Heart Association says that you can either use ceftriaxone, ampicillin, or even ciprofloxacin for about a 4-week period. The Europeans have different, kind of similar, but do have a little bit of a different view on what to do with ampicillin. So they actually add gentamicin to this regimen, for the allotted time of the ampicillin dosage. So because there's some inherent resistance to penicillins, that's why the Europeans say they do that. However, the data is kind of wishy-washy. So, but what we did is that I started this patient on he was on meropenem for some reason when I saw him, and then I ended up switching him to penicillin itself and not adding the gentamicin. And he did well and recovered. and did not have any other stigmata of infective endocarditis. Questions? Okay. Move on to case 2. 54-year-old man, day 20, out of an allograft HSCT for MDS. This was done at Shands. He was neutropenic for a period of 35 days after induction chemotherapy. So he has a productive cough, fevers, and shortness of breath. So, of course, the oncologist had him on cefepime, vanco, and fluconazole, and he had no improvement. So besides, it's not AML, I apologize, it's MDS. He had a tonsillectomy. That's the only other past medical history that's pertinent. So he's on vanco, cefepime, and fluconazole. He doesn't have any drug allergies. So his social history, he lives outside of Gainesville, not really rural, but in one of the suburbs. Originally, he's from New York, New York. He has no habits. He's a former high school teacher. He recently visited his daughter, who moved into a new apartment in North Carolina in the Piedmont area. Otherwise, he's had no other travel to New York City to see family. Hobbies, he likes to watch baseball. So physical exam, he's febrile at 38.6. He's tachy to 106. But otherwise, he's hemodynamically stable. He is on 2 liters of oxygen on nasal cannula. So he does have dry mucosa. He is tachycardic. He does have coarse breath sounds bilaterally, worse at the apices than at the bases. He doesn't have any stigmata of infective endocarditis. So, of course, his ANC is 100. His platelets are 53,000. He does have a normal creatinine, though. And his chest X-ray is shown. So it looks, again, he's got this interstitial pattern bilaterally, worse on the left than on the right, based on the rhontography. So somebody give me a syndromic diagnosis for this patient. He's a 54-year-old guy with MDS. Now he's, status post stem cell transplant. He's still neutropenic, and now he's got, a respiratory process that appears bilaterally. So give me a differential diagnosis for this patient.
So it could be pneumonia, multifocal pneumonia, and with the pneumonia, you could have fungal etiologies, bacterial etiologies are probably the most common. You could also have, I don't know if diffuse alveolar hemorrhage would present like that, but that would be another thing you got to think about. I forgot to look at his counts, but that's something else that could be the differential, I guess.
Okay, so what organisms, you said you were a little bit general there, Harish, in terms of organisms. So he's on vanco, cefepime, and fluconazole. So, and based on on where he's been, any specifics?
I think you have a little bit of blasto. It doesn't quite go up to, all the way to, he grew up in New York, so he could have a history of blasto. Depending on where you travel. If you travel out west or Midwest, you could also have a histo as one of the differentials. Okay.
Yeah, he did not do that. He recently, like I said, was, right before all this went down, he went to visit his daughter in a new apartment, like about a month and a half before getting in there, and then presenting this way. So let's keep going. So the hemonc team was worried about pneumocystis, and so they started him on IV cotrimoxazole, which is Bactrim, right? And so they consulted us to try to find a source. So my team requested to get a bronchoscopy, and pathology and microbiology were sent. The patient did improve on cotrimoxazole, though, which is strange, right? So, the GMS stain was negative for pneumocystis. Interestingly, the BAL Aspergillus galactomannan was negative as well. So, what happened? I want somebody to hypothesize why this patient got better on Bactrim. Anyone? Silence. Come on, fellows.
Hey, Dr. Cannella, it's Zola here.
Oh, hey, Zola, how you doing, man?
Yeah. No, I mean, I don't could it just, I mean, I don't know. I mean, you're saying why they got better in Bactrium, but I'm just thinking, could it be totally unrelated to the Bactrium? Could it just be
Yeah.
like a viral? I don't know. I'm just thinking like there are also like viral pneumonias as well that could occur.
Yeah, for sure. I mean, you're bringing up a good point. Again, that's reverse Occam's razor, right? You know,
I know.
it's like, what's common is common, and it could be all this was completely, at face value, and it is what it is, as what people are saying these days. But that's not totally what happened. This is what happened. Can somebody describe this for me? What is that?
So this is Jamie on the line, Jamie Morano. I'm gonna embarrass myself, but it is a charcoal agar, right? And charcoal meaning I believe it's hemolyzed red cells, right? And it's mixed, and it's a BCY Legionella. I'm a little bit rusty, so forgive me, but it's a special type of agar that has special growth, and I'm trying to think if help me out, but I'm gonna stop there. But it is a special, I believe it's a special agar. And it's either Legionella or something. Yes, go ahead.
So the good Dr. Morano is completely correct. This is Legionella. And so this agar is used as a diagnostic tool when you do a BAL or a sputa to look for Legionella, okay? So it's a gram-negative aerobic rod. It has flagellae. And so it's oxidase negative, catalase positive, produces beta-lactamases, interestingly enough. Again, water sources are its primary, ecology, and chlorination really doesn't kill it as well as we would think. And so one of the things that can happen is that you can have this, Trojan horse effect, which I'll talk about in a minute. And what it does is that they infect free-living amoeba and can hijack their cells by the cell by instituting a cyclic AMP mechanism inside of their phagosome, and thereby controlling the cell so that it's not digested. So this leads down to a Trojan horse effect, where this is how Aeromonas, Mycobacteria, and other pathogens can get inside the body when they find what the similar cell in a human would be a macrophage, right? Compared to an amoeba. Just an amoeba divide, macrophages don't. And so what happens is that then these cells can, these bacteria can get inside these cells and subsequently hang out and then come and attack when the time is right. So Legionella, again, is famous for being associated with air conditioners, aerosolized water sources. Note, he went to visit his daughter in a brand new apartment in North Carolina, which is where we thought he acquired the organism. So for diagnosis, you can get a urine Legionella antigen, or again, like the good Dr. Morano said, you can use this charcoal agar to identify it. So you can use macrolides or fluoroquinolones for treatment. Interestingly enough, though, Bactrium or Septra works. It does penetrate cells and can get in there and again, kill the bacteria. So he improved. This is why he improved on Bactrium, and he was given a 21-day course. And you're like, well, Anthony, does that make sense? Usually you treat for anywhere around a week for normal Legionella. However, with him being immunocompromised and using another antibiotic, which is not a macrolide in this case, the sulfa, you usually give a longer course, and that's why he had a 21-day course. So again, think of Legionella, and this is why patients who were on Bactrium prophylaxis for pneumocystis, not only does it take care of that and also toxo, but it can also impact them being infected with things like Listeria and Legionella, since it is covered as those. This drug also covers those organisms as well. Questions on case 2? Okay, so let's move on to case 3. So this is actually courtesy of my ex-mentor at UCSD, who's not at Yale, Joseph Vinetz, and he published a paper back in 2008, the year before I joined UC San Diego for fellowship, of an amazing case, and you can read about it in the Journal of Trop Med, which is the journal for ASTMH. It was a pretty cool study for what happened from one case. So, 79-year-old woman was found down by a neighbor and was admitted for obtundation. So this is at an outside hospital, okay? So she was confined to her home after suffering a back injury from degenerative disc disease. This has been going on for months. She lived in a very rural area near Hemet, California, which, if anyone knows, that's where the Joshua Tree National Park is. So it's basically high desert, and there's not a lot of amenities around, I should say. So her past medical history is pertinent for osteoporosis and degenerative disc disease, like I had mentioned, and hypertension. So she had no known drug allergies, and her only meds she was taking at the time was naproxen. She doesn't have any family history of any dementia, cardiopulmonary arrest, or anything else that would contribute to her presentation. So she's widowed. She lived in Southern California her whole life until she moved to Hemet about 10 years ago, and then she was also a former school teacher. She has 2 dogs. According to the neighbor, the house is very cluttered, and she could be defined as a hoarder. So she arrived at her local emergency department in Hemet, and her temperature was 38.2, pulse was 110, her blood pressure was 121/60, and oxygen saturation was 80% on room air. She was arousable, but oriented only to person. Auscultation of her lungs showed crackles at the left base, and the abdomen was soft, no bowel sounds, no lymphadenopathy. Okay, neurological exam showed no focal deficits, other than the fact that she was not arousable. So her leukocytosis was pretty impressive at almost 47,000, and there was 19% bands. So she had a renal dysfunction with a creatinine of 1.9, and elevated transaminases. AST was 336, ALT 59. Chest X-ray showed, I don't have it here, but the only thing it showed was left lower lung atelectasis. So she received a diagnosis of CAP, basically, was given a dose of ceftriaxone, and then they gave her IVs, amp-sulbactam, and at 1 dose of levofloxacin. So she did okay, and she was starting to wake up. However, 48 hours later, she crashed again. And she, her renal failure got much worse, or her creatinine got to 4.2. Her platelets went down to 54,000, and she had a pretty bad metabolic acidosis. So she was transferred to UC San Diego Medical Center in Hillcrest, which is the Southern Hospital near downtown, on day 3 for further management. She was soon required intubation and was on IHD in the ICU. So this is where it gets interesting. So the results from the outside hospital showed that she had 1 positive blood culture growing what they determined was a gram-positive bacillus. And they said it was a contaminant. So they really didn't work it up. Her LDH level increased to almost 3,300. Okay, and there was tons of schistocytes in the peripheral smear. Her PT and PTT were starting to go up. And interestingly enough, her blood cultures, when she got to UCSD, were negative. So they entertained the diagnosis of TTP, and they were going to start her on plasmapheresis. Unfortunately, her exam changed. So these are pictures from her exam. This is the picture on the left is an area of necrosis on the back of her right shoulder, and then this is her right foot where her toes were starting to become necrotic. And they took a biopsy of this, and it showed there was dermal necrosis, impressive acute inflammation, and small vessel thrombosis. Nothing was identified in terms of microbiologically. So the ampicillin sulbactam was changed to meropenem, and she started receiving gentamicin as well. So she went into distributive shock, occurred again, and was placed on vasopressors. So her CT scan is pertinent for large gallbladder, but look at her the cortical areas of the kidneys. It's almost complete just destruction bilaterally of the kidneys. So what do you do now? What's the next? You're the ID physician who is seeing this patient. The pulmonary critical care guys are like, give us an answer. This lady is basically circling the drain. What do you do? Thoughts?
Y-
Anyway,
so go on.
Yep. Go ahead. I'll let the fellows talk first.
Yeah, so I mean, it could go on.
Could be a listeria given the gram-positive bacilli. So ampicillin back on board.
okay, okay,
And
that's a thought, especially
another thing
since
with
you're probably in
mycoplasma.
her house, and, you know.
I mean, the feet remind me of proporforminans. So like mycoplasma would be another thing I would entertain.
Outstanding. Okay.
So that's one thing I would entertain. And another thing is she came from a remote part of the woods. I was thinking about like tick-borne, like in terms of Borrelia, with tick-borne relapsing fever. I mean, I got to do a little more research into, you know, in terms of his presentation, but I think it could present like pneumonia, like that. So
So it can. Usually there's a protracted undulant fever with the recurrentis, and so you'll usually see the fever pop up every 5 to 6 days. They usually don't get this incredible distributive shock though, but it is a good thought. She could have multiple organisms going on depending on what's, since she is a hoarder and who knows what's biting her in that house.
There are like some necrotic skin changes. Could be like a clostridial kind of infection, maybe anaerobic bacterium.
Okay, that's not a bad thought. Anybody else?
Yeah. So Dr. Cannella, this is Jamie Morano. I think this is. Go ahead.
Sorry.
Go ahead,
Oh,
Philip.
sorry.
No, go ahead, Philip.
Oh, no. I mean, I'm just throwing out TB out there, but I don't really think that can explain the skin issues. But I mean, disseminated TB.
Yeah, it can give you a pretty damn bad fever. In fact, in parts of Africa and Asia, it is after malaria, it's the second most common cause of fever. So, and if you were to test patients who you suspected to have, Mycobacterium tuberculosis infection, up to a third of them could have positive blood cultures for TB. That's a good thought. Again, she really wasn't around anybody at this time, but still.
Right.
But good thought.
Can I just add? Jamie Morano here. Yeah, no, these are all great thoughts. It was reminding me of a case that came out of Russia. It was actually endemic plague. So you're thinking about a hoarder, you're thinking about maybe some rodents, some fleas, maybe some ticks in there. I agree. It's interesting. I mean, Yersinia pestis, right, can present as plague. I was thinking of anthrax, if she had any, animal skins or old rugs or something, or some spores that might have come in from the environment. It's obviously a gram-positive rod, but so something like that, you can get pulmonary anthrax. You can get skin changes from that as well as scars. But absolutely tick-borne. Having a fluoroquinoline on board and a doxycycline on board, I think, would be key here. But all those thoughts are excellent. It's a very good case.
Yeah. So this is what happened. Yeah.
Hey, it's John. Sorry, I got a lot of background noise here. With her out in that area, hantavirus, it might be something else to think of.
Ooh, great. See, this is the kind of stuff that, hits fellows on boards, and they're like, well, I trained in Tampa Bay area, and the devil would I see that. But again, people travel. And so you've got to think of this. Now, I didn't tell you what time of the year this is. Usually they see a lot more hantavirus cases coming from the Four Corners area, which includes part of southeastern California, the desert area. But they usually see those cases in the spring because people are opening up they're cleaning out their barns and their sheds, and there are deer mice in there, and it's in the excreta. And so that's a very good thought. Even though I didn't tell you what time of year this was. So, any other thoughts before I move on? So this is what Joe did. So the microbiology lab at the Outside Hospital, he called them and said, "Hey, we want you to isolate the bring the isolate to us so we know what we can work it up here at the university. And so the outside hospital at the time told him, by the way, we redid the gram stain and it's a gram-negative rod. So the isolate did come to the micro lab. But the patient continued to get worse. And they were having, at this point, she was already on 3 pressors. They couldn't, her toes were falling off, and she was completely anuric almost by this point. So the subculture, the original isolate, again, like I said, was at UC San Diego, and it showed a slow-growing, small organism with small colonies, noted to be Coccobacillary with bipolar staining. It was non-motile, and it was a non-lactose fermenting gram-negative rod. And so this is for the pathology seen from the from one of the skin biopsies, I think from the back. And so you can see that there was effacement of the epidermal layer from the dermal layer, and there's an impressive amount of hemorrhage, and a lot of what looks like could be lymphocytes or other mononuclear cells that are coming in here. And again, this is I guess a 400x of that area, and again, it looks, again, you can see the destruction. This is 1000x, and you see that there is what looks like a lymphocyte, a neutrophil rather, and then you see this small. This is an H&E stain now, okay? Single organism that is bipolar staining. So you're thinking that this is an Enterobacteriaceae. It's causing this kind of picture. So that evening, which of course they identified the organism as Yersinia pestis, okay? Here is a small funny anecdote about the story. A nurse that was taking care of the patient in the ICU said that she saw live fleas in the bed of the patient, and it caused a panic. The health department and the CDC got involved. They moved the patient out of the room, and then they sent the fleas to the health department. They were determined to be fruit flies, actually, from somebody who brought a fruit basket into the ICU, which was put in the paper. It was slightly amusing. So the patient received 10 days of Levogent and Doxy. She had an extended hospital stay. She was, again, remained anuric, did not want to undergo dialysis, and so she basically succumbed from her uremia. So this was plague, and so septicemic plague to be exact. And so the CDC and the California Department of Health got involved, like I said. And so what they did is that they captured squirrels, deer, mice on her property. And then they noticed that there was a deceased lagomorph, or rabbit, basically on the property. And so they took blood from that. And they also took blood from 2 of the patients, blood from both patients, from the patient's 2 dogs. And so 2 of the 3 ground squirrels tested positive for antibodies to white pestis with extremely high titers of 1 to 2048. Suggested that they had a recent, more than likely had a recent infection. One of the 2 dogs tested positive with antibodies to white pestis to 1 to 64, and the rabbit's blood was positive for white pestis, indicating that the rabbit probably succumbed to plague. So let's talk about Yersinia pestis. So again, it's a non-fermenting gram-negative rod, Enterobacteriales, as the good Dr. Mercurio said last week. Or the week before. And the treatment is really aminoglycoside and tetracycline. You can use a fluoroquinolone. It's kind of, even though it's part of the regimen, there is some debate about it in terms of its immunosuppressing effect, but I'll get to that in a second. So there's this 42-hour period to make the diagnosis, and there's a reason for that immunologically. So anybody who has exposure usually gets a tetracycline and then maybe a fluoroquinolone. So beta-lactams are contraindicated, interestingly. Carbapenems may not be. There's an ongoing study right now that I'm part of a PhD committee still at the University of Florida, the Lake Nona campus, of a PhD student who's actually looking at how fluoroquinolones could impact the immunomodulation regarding infection, natural infection to Yersinia pestis in the Colorado 92 strain, which is the standard bearer for Y. pestis in labs. And so the reason that beta-lactams are contraindicated is because when you start blowing up Yersinia pestis in the bloodstream, it's not just the LPS that's the problem. So Yersinia also has these things called YOPs, or Yersinia outer membrane proteins. And there are some in enterocolitica and also pseudotuberculosis, but the ones that really cause disease are associated with Yersinia pestis, and they do the following. So they produce, one of the parts of these YOPs produces a soluble IL-1 beta receptor. And so what that does is that chews up IL-1 beta, globally, and so that again reduces the immune response at the beginning. It also creates one of the YOPs is also an enzyme that cleaves IL-18, and thus really depresses the immune response within that first 24 to 48 hours. And again, but around hour 40, things start to surge. So this is taken from a Cytokine Frontiers paper a couple years ago, and it demonstrates the IL-1 family of cytokines. And I know people are probably like snooze, but it's kind of important because if we know that these YOPs impact two huge parts of the IL-1 family, then you have to understand why starting a beta-lactam, if you're thinking that pestis is the causative organism, might not be the best option. In addition, why there's this indolent presentation, and then finally an explosion basically of immune system presence to the organism. So as you see here, what IL-1 alpha and IL-1 beta, they stimulate through capsase 1. They can stimulate IL-6, IL-21, IL-23, and that's usually done through a Th17 CD4 cell. And what does that do? So again, this would depress neutrophils from getting into places like the like the mucosal areas of the body, including the lungs. And this is what the IL-1 receptor will do, is to block this. So IL-18, which also goes through kind of this capsase 1, stimulates IL-12 to produce IL-2, IL-15. And what do? Well, they do a broad range of things, whether that's a Th1 response for these CD4 cells to stimulate CD8 to destroy macrophages that are infected after interferon gamma is released. And then you've got, again, the same thing with it, like I just said, CD8s. Then gamma delta T cells in the mucosal area are also stimulated, and they produce interferon gamma. Same kind of thing. They can also lyse macrophages as well, and NKs as well. And then you've got IL-33 and IL-37. I'm not going to really touch on them, but they can stimulate more of a Th2 or Treg response which causes this anti-inflammatory like picture, and can kind of partake into what's going on with infection. So I'll update you at some point with regards to the PhD student's efforts. She's halfway through her PhD and getting some pretty interesting results in terms of some other cytokines which are probably affected by Y. pestis infection. Any questions on case 3?
Anthony.
Yes.
It's John. This is obviously a potential bioterror weapon, and that anytime that somebody rolls into an ED with bloody sputum, a hemorrhagic type of that should really get your attention. If you get 2 or 3 rolling in pretty closely together, that's when you need to really let people know that you think there's been an event. And Essence would probably let us know that as well. The way we used to talk about this during the bioterrorism presentations that we used to do was that bipolar staining on a Wason stain, although nobody does a Wason stain anymore. Mm-hmm. And the whole issue is prophy. You have to prophy basically everybody that person was around, which can be difficult. And with this one, there was a similar outbreak in Colorado with a guy who went to see his friend, and friend had a cat, and the cat seemed to be sick, and it crawled under his house. So the guy went under the house to get the cat. They took the cat to a veterinarian who was really concerned because this cat had an appearance that he thought could be plague. And it ended up that the one guy who went to visit his friend ended up with plague. And he did survive, but they had to go out and then treat with insecticide. I forget how many. It's a huge area around in this guy's house to try and kill all the fleas off. So it can certainly happen this way, but the other concern is a bioweapon event to be really cautious about.
Right, and I think that whenever you see a gram-positive rod on a blood culture, don't assume it's just Listeria or part of the Bacillus cereus group or something else. Actually ask them to do some old-fashioned microbiology, and I think we've lost a lot of this in ID, where if you see that it's Bacillus species and it's spore, it could be spore forming, ask them to do a motility test. If it's non-motile, you've got anthracis. These are things that I learned in fellowship that we take for granted and just go on to the next case. But again, like you eloquently said, this is a lady who is from literally high desert California. She's a hoarder. She's got dogs, and there are animals on the property. And she grew this organism on the blood culture, and an astute microbiologist would make sure to do the gram stain correctly. In this case, it was not done correctly, and that's why it was a gram-positive rod. And they kind of blew it off, unfortunately. And so, which could have led to her diagnosis and probably proper treatment earlier. Again, Monday morning quarterback, it kind of comes into play, but at the same time, the other interesting thing is that, when Joe asked for the sample to be FedExed, he literally FedExed plague across Southern California.
Oh, God.
And so, he didn't know. He was just trying to get the isolate to do the right thing microbiologically, because he did think that the presentation was strange. And that generated a whole hoopla of CDC and stuff like that. Getting involved.
Yeah, and it's also important. I mean, like you say, the old microbiologists would note that these colonies are really mucoid, and you get a string test from them. Mm-hmm. When you're pulling them off the plate, they do have that kind of mucoid stringy-like appearance. So, but it's a great case. Thanks.
Yeah. So let's move on to the last case. This is this occurred. This is what you're looking at is Donovan State Prison near the border of California and Baja California, Mexico. And as you can see, here's the border, and you can see that there's tons of houses on this side of the border and nothing here except for a prison. So this consult came in on December 31st, 2009. So, and you're like, well, who cares? Well, it was the last day of that rotation as when I was a first year fellow, and it came in, of course, at 4 p.m. So the fellows can kind of relate. But again, this case illustrates that you've really got to be on your toes, regardless of when it is and what day of the rotation it is. So patient is a 39-year-old African-American guy who presented to Medical Center Hillcrest from UCSD, who was found unconscious in his prison cell 3 weeks earlier. So the nursing notes said that it was 1 month history of worsening confusion prior to him showing up to the infirmary and then subsequently to UCSD. So the chart noted that he had, during his internment, at the prison, he had global weakness and a 60-kilogram weight loss over the last year. So the chart noted methamphetamine use, but he quit about 2-3 months before this. So he was admitted to the MICU at Hillcrest with progressive neurological decline. He was in the ventilator in a coma, and he had this this fluctuating temperature range with pretty labile temperatures. So his past medical history had bipolar disorder. We really don't know his family medical history from the chart because we couldn't talk to him. Social history, he was married, no other recent sexual partners, and there was no MSM documented. He lives in El Cajon, California, which is an eastern suburb of San Diego. No pets. The chart did state that he had cocaine, heroin, and amphetamines noted in the urine on a tox screen. Was a tobacco user, no alcohol use that we could decipher, and obviously no recent travel. He was incarcerated. So no known drug allergies, and his only meds was lithium, and he wasn't getting that at the prison. So vitals, he was had a temperature of 38.0, pulse 110, blood pressure was slightly elevated diastolic at 95. So he was ventilated, sedated, he's a thin guy, no lymphadenopathy. He definitely had temporal wasting. He had reduced breath sounds bilaterally. He did have some hepatomegaly, interestingly enough, and there was reduced bowel sounds. He did have reduced deep tendon reflexes. So his labs, his white count was within normal limits. His hematocrit was 29%, and his thrombocytes was 131. So AST and ALT were elevated. Total protein was 4.9, albumin 2.1. Bilirubin was okay. They did a lumbar puncture about a week before, and his white blood cell count was 178 with 81% lymphocytes, and red blood cells 9, glucose 27. His total protein was 730. So the MTB PCR was pending at the time, and so was the coccidioides complement fixation. His HIV antibody was negative, and his IgG total and the subclasses were within normal limits. So I will do the syndromic diagnosis for him. 39-year-old African-American man who is incarcerated with neurological compromise due to a chronic, likely infectious process, which based on presentation and data demonstrates dissemination of the pathogen. I suggest to the fellows, this is how you put it in the chart. This is how you do the impression in the impression and recommendations. And I know that's a culture shock, but for billing purposes, this describes exactly what's going on with the case. Number one. Number two, it describes to who's reading the note that what you're thinking. And you're like, well, people don't read the notes. But this was important because what was in the chart is what kind of led to the diagnosis on this patient. And again, if notes are not written in a way where people, physicians, other physicians and other clinical, parties can understand, then it could lead to a delay in diagnosis, such as in this case. So his chest X-ray is shown, really not helpful. A little bit of haziness on the left-hand side, and some interstitial pattern, but nothing really to walk home about. So here's CT thorax. There's a little bit of what looks like a rind kind of forming here in the lung, some wispiness in the left, in the lingula, and this is, I believe, this is the superior segment of the left inferior lobe, which is kind of encased in a material there. CT head just shows slightly enlarged ventricles, but otherwise okay. And MRI just shows that there's some kind of inflammatory process going on in the posterior horns of the lateral ventricles. And again, there was motion artifact, but there could be something going on within the brain stem here. So I'd like a differential diagnosis based on on the radiologic data that I showed you, and also the syndromic diagnosis that I gave you. Fellows first, please.
I mean, you could always consider syphilis, neurosyphilis.
Okay, not a bad thought. Anything else?
This is Jamie Morano. I think this is definitely a great case. I think the desert is really maybe key here. I'm always the boards love to ask about desert arthritis, right? Which is coxio. Crypto may be less likely unless there's some kind of T cell deficiency, or Hep C on board, which is interesting too. And yeah, no, definitely something causing systemic function. I think the brain is lighting up from that as well. But that would be, I see it's HIV negative. That's reassuring. Also, contaminants of drugs. I don't think it would cause that long a weight loss. And then, of course, NTM really wouldn't cause the fevers per se. I was thinking leprosy. We're talking about the tendons and the nerves, but it sounds like they weren't thickened, which would, and obviously leprosy doesn't present like that, the Hansen's disease. But I would think a coccidioicosis or some kind of desert-related infection, blastohisto of the spine, could be maybe a dimorphic fungus of some sort. We think of fevers and weight loss maybe with the fungal families. That's just my 2 cents.
Yeah, outstanding. I think that to piggyback on that, Jamie, Cryptococcus gattii is endemic along the coast of California, going all the way up into British Columbia, and we're starting to see that patients who are immunocompetent in this area, because there's so many eucalyptus trees, which the fungus feeds on, that they can actually, you'll see cases of this in immunocompetent people. So it is a great, I do agree it's a great thought. Anybody else with any kind of differential diagnosis? Okay, well, we're getting close to the end, so let me just get to it. So the MICU wanted to give him glucocorticoids for the brain inflammation. I mean, they probably should have done that 3 weeks before, but hey, whatever. But our differential diagnosis was disseminated mycobacterial tuberculosis and also coccidioides. So glucocorticoids and disseminated cocci infection are contraindicated. Doing that could cause a huge, huge, huge problem. I saw tons of cocci in California, and that is a big no-no. But we need another sample to determine the pathogen. So what do you do now? Fellows, this is you, and now it's about 5 o'clock after you reviewed the chart, seen the patient, looked at all the data. You need, what else would you do?
You could get the blood antibody for cocci.
Okay, so Kopman fixation, which was sent, it's in process.
I think you mentioned that he had a hepatomegaly.
He did have hepatomegaly.
So you could probably go after an abscess or a lesion in the liver.
Okay, good thought. Any other thoughts before I move on quickly? Okay, so this is what I did. You always go back to the history. If you go back to the history, there are little details, and I'm sure John Tony will echo this and everybody else. The devil's in the details in these cases. So you've got to re-review the chart. So the patient reported flank pain initially when he came to the infirmary in his review of systems. That was not in the history and physical when he was brought up to the NICU. So we recommended a stat CT abdomen and pelvis. This is what we found. As you can see here, this is his left psoas muscle, and there is something necrotic going on in the middle of it. This is the coronal cut, and you can see that both L1 and L2 are being destroyed by something, and as well this very large longitudinal psoas abscess going into the iliopsoas part of the muscle. This is the sagittal section, cuts of both the L1, L2 vertebra, again, kind of collapsing. Posteriorly, though, not anteriorly. And you can see that there was, again, this huge pus pocket, fluctuance rather, within the psoas muscle. So we told IR to come back into the hospital from their New Year's Eve party. And they did CT guided aspiration and got 20 milliliters of extremely purulent material. I walked the specimen down there myself at around 7:30 to the microlab, and we sat there in the microlab until we got a result, which was about 2 hours later. And the gram stain showed a heavy inflammatory infiltrate, but there was heavy AFB. So we started him on right vitamin B6, of course, and glucocorticoids at about 10 p.m. In 3 weeks, M. tuberculosis grew, was pan-sensitive. Unfortunately, because of his neurological complication, was so profound that he died 5 days after beginning treatment. So again, I talked about MTB last time, so I'm not going to go through all this, but I will go through a little bit of the history and some of the pathophys, again, because it's important to know. So in ancient Egypt, it was noted, Middle Ages as well, they associated with vampires. Dr. Richard Morton from Germany, Britain, described these as lung tubercules in these patients. And then Dr. Johann Lucas Schonlein of Schonlein purpura from IgA vasculitis coined the term tuberculosis. Interesting enough, he also was the first person to identify trichophyton as well as a pathogen. And then, Robert Koch, who is really synonymous with TB, was the first person to view the bacillus. And he related his findings to the University of Berlin's Institute of Hygiene. And that was actually on March 24th, 1889. And that's why March 24th is World TB Day. So M. tuberculosis, M. africanum, M. bovis, and M. microti are the most common species, but there's 6 other ones as part of the complex. So yeah, we know it's the top risk. It's one of the top causes of death in the world. There's a huge association with HIV. I'll kind of go through this. Again, this is the TB rates from 2016. You can see that most of the cases are in Southern and Southeast Asia, as well as Sub-Saharan Africa. But then when you when you mirror that map with people with HIV status, you can see that it's ubiquitous, except for in parts of Western Europe. So let's talk briefly about TB meningitis. So it's 5% of all extrapulmonary TB, 0.7% of all TB. And again, there's a greater incidence in HIV patients. The fatality rate can be anywhere from 15 to 40%, and about a third of them can have miliary TB. So what happens? So again, you get droplet infection, becomes bacteremic with MTB, and it can penetrate the meninges and brain parenchyma. You have a rich focus along the arachnoid, and so then it can rupture into the arachnoid space. And that can cause a couple things: adhesions, which occur with nasal cisterns and also some of the other fossae, and that's where you get hydrocephalus and some of the sequelae from that, like the nerve palsies, cranial nerve palsies. You get encephalitis, of course, which can lead, brain, because of brain edema, and again, more increase in the ICP. But what people really die of is a vasculitis, and it's usually some kind of cerebrovascular accident, specifically in the brain, in the basal ganglia. And so what we know, and this is a postmortem picture, is that for some reason there's this predilection to the circle of Willis, and so that's why looking at the brainstem is very, very, very important on CT and MRI if you're going to pick up tuberculous meningitis. It's really important. And again, the tip-off is usually the CSF having a very high protein level. Sure, could you have a high protein level in some endemic fungal infections and other things? Absolutely. But classically, MTB has to be considered in the differential, and that is an ID board question. So please be aware of it. Again, the prodromal, the features, you have a prodromal phase, which, again, malaise, headache, fever, meningitic phase, where you have this meningismus, cranial nerve defects, and then finally the paralytic phase, where you have stupor, coma, you start having, seizure activity, and then hemiparesis. So that's classic for what you could see. And if you think about this patient's presentation, that's exactly what happened. So I'm not going to go into this. We can talk about that at another time, almost out of time. And then final question, who is this? That's a historical figure who classically had tuberculosis. I know John Tony's going to go for that.
Lots of people did.
That's not Samuel Clemens, is it?
No, it is not. This person died in his 30s, late 30s or early 40s, I believe.
Was he a musician?
Negative. He was not a musician.
Okay, I didn't think it looked like Woody Guthrie.
No. So
was he an inventor?
No, he is not an inventor.
He's a writer?
He was a what?
A writer?
No, he was not. He was a killer and a dentist. So this is John Henry Holliday, also known as Doc Holliday, from Wyatt Earp's group, and was one of the people who was present at the OK Corral at the Battle of Tombstone in 1881 in Arizona. And so he's famously played by Val Kilmer in the movie Tombstone, and did a great job of the character, did the character a lot of justice. But he famously died of tuberculosis. So again, it's a little tidbit. I hope you guys like the cases. I have a bunch more that I could present at some other time. So any final questions? I'm sorry I went over.